So it's a pleasure to be here with you virtually, and I'm going to talk about the first part of the myxomatous mitral valve disease and concentrating on classification, incidence, pathology and pathogenesis. So we're going to go backwards and forwards a little bit among those things. But first of all, greetings from the University of Liverpool. So this is the Small Animal Teaching Hospital where I live, and this is out of Liverpool. It's in the Wirral on the Lea Hurst campus, so you can see that from the air here, and that's one of my patients. And Liverpool was one of the original British red brick universities, so this is the Victoria building, which shows you why. So our journey this morning is to go through the various aspects of mitral valve disease. So we're going to talk about the prevalence or incidence, the pathological classification. We're going to review the pathology, and I'm grateful for images from pathology colleagues and people carrying out research in this area. And so we'll look at that. We're going to look at the pathophysiology of mitral valve disease and then the clinical or imaging classification. We'll then go back and have a little think about the pathogenesis and etiology of the condition. We'll think again about the pathophysiology as it progresses and some of the sort of sequelae that we might see with end-stage mitral valve disease. So mitral valve disease has a lot of different synonyms. So I guess these days most people call it myxomatous degenerative valvular disease or myxomatous mitral valve disease. An old name is valvular endocardiosis, or people simply call it mitral valve disease or degenerative valvular disease. Very old names called it valvular fibrosis and things, but it's the same condition we're talking about. So we've obviously known about this for a very long time in dogs, and we'll look at some of that history, but it does occur in humans. So this is one of the earliest papers I found about myxomatous degeneration of the mitral valve, and they suggested that it should be considered as a cause of acquired mitral regurgitation in people, but the prevalence is very much lower in people, sort of less than 1% or so of the human population, and it is age associated as well. So when we think about prevalence or incidence, I guess we should think about how these are defined. So prevalence is how many cases at a particular point in time, whereas incidence is the rate of occurrence of new cases in a defined period of time, so whether that's 5 years or 1 year. So I think we're mainly talking about from what's published about prevalence. And there's a very good survey among electronic patient records from nearly 112,000 dogs that has been presented, saying that in a kind of population of all consultations, the prevalence estimated about 0.36% of all cases. So this is all ages with confirmed cases, but going up, these are cases with characteristic heart murmurs of 3.5%. So clearly we all are aware that this is more common in small breed dogs, and it's more common in older dogs, and there's a slight male overrepresentation. So if you have an older dog over 8 or 10 years old, the prevalence can be sort of 90%, even over 100% in some breeds like the Cavalier. So in the ACVM consensus statement about myxomatous mitral valve disease that was published in 2019, it was stated that approximately 10% of dogs will have heart disease, and mitral valve disease is the most common heart disease, explaining maybe about 75% of those heart disease cases. So I said it's a very well recognised condition in veterinary medicine, and this is a paper going back from over 50 years ago. So this was pre-Echo days, clearly, but Don Patterson and de Twyla actually had this prospective study looking between 1955 and 1964 about animals coming in. They screened them for heart disease by physical examination and an ECG. And if they thought they had possible heart disease, they carried out full investigations, which in those days included cardiac catheterization, radiographs, angiography, but not echo clearly. But it did include necropsy for those dogs that didn't live. So there was a very common chronic valvular disease. So we had chronic valvular disease in 6% of the dogs identified, whereas heart disease may be affected up to 11%. And they showed very nicely that different ages you had more common chronic valvular disease in our older dogs. So in veterinary medicine, we have known about it for a very long time. And one of the seminal publications was the pathological classification of chronic valvular disease in the dog. And this was by Whitney, and this is back in 1974. But this classification is still very much used for staging severity in various research studies that we will review as we go through this session. So the first session is our type 1 valvular lesions, where just at the point of leaflet apposition, we will have little nodules and that are fairly opaque compared to the normally fairly translucent valve tissue. Then our type 2, we have sort of more coalescing of our valve leaflets, so they're getting a little bit more severe, and there may be sort of almost this opacity, plaque-like opacity between them. Then we start seeing with stage 3, larger nodules, they sort of tend to coalesce. We can end up with these irregular plaque-like deformities, and they can extend to involve the chordae tendini as they attach onto the valve. So for our type 4 lesions, these get very much more severe. The leaflets are very distorted. They tend to curl inwards into the ventricular side, so they tend to be relatively shorter. As they oppose, there's more of a mitral regurgitant orifice, and the valve leaflets tend to balloon during systole. So this classification isn't necessarily always clinically applicable, but it is used for research staging, and it's still used very much at this day. And obviously it's a continuous progression through these phases. There's not a one day I'll become stage 3. So that's the kind of thing we've got to think about. So this is my colleague, Brendan Corcoran, who I used to work with, and he still remains a mentor and a friend, but he's been recently carrying out a lot of really good research in mitral valve disease at the University of Edinburgh. So this is, again, showing some glorious Technicolor images compared to the black and white of the 1970s. But I guess mitral valve disease is considered almost a ubiquitous condition, so it will affect any old dog. So where we see these little nodules at the edge of the leaflet, that could be normal, but it's classed as our grade 1, but it could be a normal aging change. And if it occurs prematurely, it causes the disease that we think about. And so we can see these leaflets minimally affected, and we can still appreciate this almost relatively translucent leaflet until you get to the leaflet tips. And then as our condition gets much worse, we see these sort of severe inturning of the valve leaflets, real severe thickening. The whole leaflet becomes opaque, and you can see as they're closed, so we're looking down from the atria into the ventricles, that they're sort of rolled inwards, and this is sort of contributing to our severe regurgitant orifice. With mitral valve disease, it doesn't just affect the valves themselves, but it can affect the whole of the mitral valve apparatus. So for that, we should think about the papillary muscles, we should think about the chordae tendini, we should think about the valve leaflets themselves, but importantly, the walls of the ventricle, the walls of the atria, and they all contribute, and they will all be affected by progressive mitral valve disease, as we will see, which will all affect valve function. So this is what we see with our sort of progressive disease. So there's a sort of certain redundancy of the leaflet tissue. So during ventricular systole, associated with the mitral regurgitation, as you can see from the image on the right, with the colour flow Doppler showing severe mitral regurgitation, you can see during systole that there's this severe ballooning up of the valve. So on the still image here, you can actually see this is often called a parachute valve. So this represents mitral valve prolapse, but this is a sort of particularly severe case in a whippet that looks very, very florid and very abnormal. So this is what the valve pathology leads to clinically that we're used to seeing. So carrying on a little bit about the pathology, we'll go back to that, and we'll think about histopathology for a little bit. So we have our normal mitral valve tissue shown here with a sort of H&E stain, and this is normally what we see. So we have this distinct laminated structure. So on the atrial side, we have our atrialis layer. So these are basically endothelial cells, and that overlies some elastic fibers. And the other predominant cell type within the valve, apart from the endothelial cells on either surface, are valve interstitial cells. So these are quite fibroblast-like. So on the atrialis side, there are occasional smooth muscle cells, but basically these are this is our atrialis layer. Then we have this sort of less cellular spongiosa layer, and this represents the sort of normal accumulation of glycosaminoglycans and proteoglycans. There's sort of some loose collagen fibers. They're not very organized. There are occasional valve interstitial cells. In the proximal part of the valve, as it's inserted into the walls of the myocardium, we do see some adipocytes, and there's maybe more of those with age. That's likely not to be part of the pathology. Then we have our fibrosa layer, where we have these sort of very dense, organized collagen fibrils with lots of cross-linked mature collagen that's circumferentially arranged around the valve on the more of the ventricularis side, and these carry on, they continue into the chordae tendini. And then finally we have our ventricularis layer, where we will have our endothelial cells, and these are overlying some elastic and collagen fibers again, with occasional valve interstitial cells as we talked about. So this is what it should like, this nice distinct laminated structure. So in contrast, we have lost our laminated structure in our sort of very severe Whitney grade 4 mitral valve lesions. So it becomes very much more disorganized. So these changes tend to be in the distal part of the valve more than as they attach to the myocardium. There's this progressive expansion of the spongiosa layer with greater accumulation of our glycosaminoglycans and our proteoglycans, and there's more water accumulation within the valve as well. And our fibrosa layer becomes disrupted. So instead of our nice mature collagen, we have these sort of more changed to fibrillar, less cross-linked collagen, and it becomes much more difficult to tell the difference between our spongiosa layer and our fibrosa layer. So the typical nodules that we will recognise on echocardiography and see at gross post-mortem, this is really due to an expansion of the spongiosa layer. So there's this excess of deposited sort of almost mucinous extracellular matrix, and then these changes will result in this sort of nodule, or eventually develop this myxomatous nodule, expands into that sort of appearance. So this is what gives us our nodules that we see with the mitral valve. One thing that the canine myxomatous degenerative valve does not show is it does not show a lot of fibrosis. As you see, there was normal accumulations of collagen in a normal valve, but there isn't a surplus of fibrosis. And this is despite the old names of valvular fibrosis, or the Ettinger and Suter book, which is the Bible from the 1970s. I still have a copy, but it was called in that book chronic mitral valvular fibrosis. But as you see from the histology, we really don't have this surplus of fibrosis tissue. One of the equivalent conditions in the human is believed to be Barlow syndrome. So this tends to be called mitral valve prolapse. But when we call it mitral valve prolapse, we're ignoring the initial pathology, which is myxomatous degeneration. But in the human condition, we have this extensive superimposed fibrosis on top of the atrialis and the ventricularis layers. So this is stained with an elastic stain, so we can see the black elastic fibers just beneath the atrialis and the ventricularis layers. So this seems to be very similar, although Barlow syndrome is much less common in people than mitral valve diseases in dogs. Another cause of mitral prolapse in humans is fibroelastic deficiency, but this has quite a rapid onset, and it's due to deficiency of base components of the connective tissue matrix of the valve. So Barlow syndrome is probably the most similar condition, but it's very interesting that in the human condition we have lots of fibrosis, in the dog condition we don't. These are some more stunning images, I feel they're stunning, from Professor Brendan Corcoran. And he did some scanning electron microscopy of a normal mitral valve here. So you can see the nice smooth atrialis layer of the valve itself and how they connect to these nice slender organized chordae. And then on the right, we have an abnormal valve. We're seeing that sort of leaflet tip incurling, the nodules, and we also see a ruptured chordae tendini, which this wasn't a fixation artifact. This was actually part of the naturally occurring disease. So we can see how different on this sort of structural layer these valves look. So some more EM images from Brendan Corcoran. So this is a transmission electron microscopy, so we're actually looking at a section through the valve. And this is what the normal valve looks like. So the normal cellular components, as we said, the most common of these are your valve interstitial cells, which you can see on the left here with its nucleus. And you can see this nice organized collagen bundle here. It's compacted, it's organized, it's cross-linked, it's mature. So this is our sort of usual valve interstitial cell that's nice and quiescent. We see this euchromatin edge to the nucleus. And then conversely, on the right, we have a sort of disease cell. We can see, again, a valve interstitial cell again here. But our collagen, we have it very disorganized. It's sort of this fibrillar, disorganized collagen. It's immature. It's failed to maintain these cross links. And this valve interstitial cell has this sort of heterochromatin rim showing it's sort of activated as well. So there's some really beautiful images, and then here's some more from Brendan. So he's showing again with another scanning EM. We can see the normal valve endothelium, so it's almost like a paving stoning. So this is higher power than the images I showed you before. But we lose these epithelial cells, so we have this sort of denuding, and we're exposing the valve stroma, as we're seeing in these middle and right hand images. That seems to be part of the pathology as well, and presumably could lead to activated platelets and things like that. So the consequence of all these changes gives us the disease that we're well used to recognising from echocardiography. So this is a left apical 4-chamber view where we're lined up with the transmitral flow and the mitral regurgitation. And I think the colour flow really illustrates well between the left atrium and the left ventricle that we have the volume overload of the left atrium and left ventricle. So a mitral regurgitation that goes up in the left atrium all goes back into the left ventricle, and rather than most of the blood from the left ventricular stroke volume going forward out into the aorta, a significant component of that is mitral regurgitant stroke volume. So you can see how this volume overload leads to progressive left atrial and left ventricular dilation. So we will end up sort of stretching our mitral annulus, and as the left ventricle becomes quite rounded, we also have the issue of our mitral valve apparatus is disrupted. So we have our papillary muscles and chordae are sort of tending to pull apart the valve rather than to try and keep it nicely aligned and supporting the mitral valve apparatus. So we have this phrase about mitral regurgitation begets mitral regurgitation, but you can see how this happens with the altered geometry of the left atrium, left ventricle, and the stretch of the mitral annulus, regardless of the valvular changes itself. So we have this brings us on to our sort of clinical and imaging classification of mitral valve disease. So we have our ACVM consensus statements about the diagnosis and management of mitral valve disease. So these were first published in 2009, and there's been an update recently published in 2019. And so obviously the evidence base for how we treat and manage these cases has been updated, but the change to the classification, which is the ABCD classification, is one of our preclinical stages for stage B2. That has shown there's enough left atrial and left ventricular remodeling to meet the EPIC study inclusion criteria. So what is the EPIC study? So the EPIC study was again published in the Journal of Veterinary Internal Medicine by Adrian Boswood and a number of international collaborators, and it looked at the effect of pimobendan in dogs with remodeling, so left atrial, left ventricular enlargement due to mitral regurgitation, and they were in the preclinical stage and they were randomized to receive either pimobendan or placebo. And the event that they were interested in was either onset of congestive heart failure or a cardiac death. So these are Kaplan-Meier graphs, and so you've got 100% of the dogs all in the study. In the green we have the pimobendan, in the blue we have the placebo. At the point at which 50% of the dogs have reached their endpoint, the time to that endpoint was significantly longer in the Pimabendon dogs by more than 400 days. So this is like 15 months of additional symptom-free life before the onset of congestive heart failure. So this means it's very important for us to be able to identify this stage of the disease. More importantly, it's more important for the dogs that we identify this stage of the disease, because once they're in congestive heart failure, they still have this unrelenting course. But to maintain that asymptomatic period is very important for those individual dogs. So just to review those stages, I'm sure everybody's quite familiar with these, but our stage A is meaning you're at risk of developing the disease. So if we eventually have a genetic test, or just being a cavalier means you're at risk of developing the disease at some point during your life. And stage B is this preclinical stage, so pre-onset of congestive heart failure. So with the stage B1, we have no evidence of significant remodeling. So we may have no or only mild left atrial left ventricular dilation compared to reference values for that breed or that weight of dog. And with our stage B2, we have this evidence of significant remodeling meeting the epic inclusion criteria. And so this is compensation for the mitral regurgitation induced volume overload. And then our stage C is the onset of congestive heart failure that we treat in the usual way. And with stage D, these are sort of our end stage congestive heart failure that may have sort of advanced sequelae, which we'll look at a little bit later. And it means we do need to have additional tailored treatment for these cases. So as we said, in this preclinical phase, it is really important we are able to identify the stage B2. So for stage B2, for the epic inclusion at least, they have to have left atrial left and left ventricular dilation. So our evidence for left atrial dilation is our short axis basilar right parasternal view, where we've got the aorta in the center of the image, and then we compare the left atrial diameter to the aortic diameter. So the aorta is like an internal size control. So this ratio is independent of body weight and things. So you can see, and this is an example of stage B1, our left atrial to aortic ratio is 1.42. And in stage B2, this is a more advanced one. You can see that the left atrium is more dilated with its atrial appendage, and it's our ratio in this dog is 2.02. So this one would clearly meet the B2, as long as it also had left ventricular dilation. So for our left ventricular dilation, we're looking, because of the volume overload is going to affect the diastolic volume and diastolic diameter of the left ventricle, and we typically will use an M mode. So the M mode cursor is positioned through the right parasternal short axis view at sort of chordae tendini level, so the widest part of the left ventricle. And then we're looking at the interventricular septum and the left ventricular free wall motion, and we can measure the internal diameter of the left ventricle in diastole. And we can index this for body weight. So we means we don't have to have breed-specific ranges for every single breed, but our index is over 1.7 for our epic inclusion and our stage B2 criteria. So in this case, it was 2.18. So how do we get that index? So that index is based on allometric scaling. So this is a paper published quite a long time ago now in 2004. There's a recent update published by Gerhard West and Jens Hagstrom's group in JVIM in 2020. But basically they tried to normalize the internal diameters of the left ventricle in diastole and systole and the wall thicknesses in diastole. So we're interested in the left ventricular internal diameter in diastole. And our index is basically our measured diameter divided by approximately the cube root of the body weight. But that actual exponent isn't always exactly the cube root, so we've got the exponents down here, so depending what we're measuring. So for our left ventricle in index in diastole, our reference ranges are between 1.27 and 1.85, but our epic inclusion criteria said it had to be above 1.7. So you can see we have to be out with 5% of the population for our reference range for the epic inclusion criteria. But interestingly, the recent paper by the West group showed that this was probably more real for the sort of a very much larger number of dogs, sort of over 7,500 dogs. So 1.7 seemed to be the top end of their reference range. So this is how we get to the index anyway. So B2 actually ranges quite a lot. So we have some dogs, we see quite a lot of dogs for staging for mitral valve disease before they get onset of congestive heart failure. And we have some dogs like this, that they just about make it. So their left atrial to aortic ratio is 1.61, so that is greater than or equal to 1.6, and then our index is 1.72. So this dog just makes it into epic inclusion, so he's entitled to get some bumerbendin. Whereas other dogs, it's much more clear cut. So this dog has a very big left atrium and the dilated left ventricle I showed you previously. So it's important for the dog we identify this stage. And then our stage C is the onset of congestive heart failure. So this is the sort of our bread and butter cardiology in general practice. So they'll come in with sort of coughing or shortness of breath. Typically, they'll have a very loud characteristic heart murmur. And we can end up with radiographs showing this sort of fulminant pulmonary edema with a sort of interstitial alveolar pattern that's predominantly perihilar. So that's very typical of canine congestive heart failure. And we have a sort of pulmonary venous distension here as well. So before we get to that stage, if we know the dog has preclinical mitral valve disease, and maybe we think it's an advanced B2, then it is very important for us to instruct owners about home monitoring of sleeping and resting respiratory rate, because the first thing that happens as your left atrial pressure increases, your pulmonary capillary pressure increases, the lungs become more stiff, and so the animal breathes more rapidly. So this will occur prior to overt dyspnea. So rather than crashing into congestive heart failure, then we know we can intervene with frusemide without a sort of need for sort of aggressive diuresis and hospitalization. And along with the sort of onset of congestive heart failure, we have our sort of typical increased sympathetic stimulation, so we lose sinus arrhythmia, we have a sort of more regular heart rhythm, almost metronomically regular, we could have arrhythmias, and we have activation of our renin-angiotensin-aldosterone system, so our treatment might be directed against those things. So we talked about this being much more of a condition of our small breed dog friends, but it does occur in large breeds. It's not so commonly a cause of congestive heart failure, but a lot of older dogs, whatever their size, will tend to have degenerative valve disease, heart murmurs at least. But we will occasionally see them present with very severe congestive heart failure. So this is a German Shepherd that was in biventricular congestive heart failure, and you can see he's also got atrial fibrillation. So our typical things with degenerative mitral valve disease in larger breed dogs like German Shepherds or Border Collies is that they tend to have less florid and less prolapsing valve leaflets. They still have severe mitral regurgitation and appropriately loud heart murmur, but they will get sort of impaired systolic function as well. So on his M mode here, you can see he's actually having some ventricular bigeminy as well. So he doesn't look typical of a dilated cardiomyopathy. He's not got such diminished wall motion, but he does have impaired systolic function. And we have to remember this mitral regurgitation offers a low afterload to our left ventricle, so our fractional shortenings and ejection fractions will tend to be high. So we have to rely on our systolic diameters or end systolic volume index to identify that systolic dysfunction. So this is sort of fairly well recognised. They don't sort of compensate for as long. They have their systolic dysfunction, and also they're more likely to develop atrial fibrillation. And certainly that's noted to be a sort of poor prognostic indicator in medium or large sized dogs with mitral valve disease. The other thing this German Shepherd shows is severe muscle wasting. He's obviously ascitic, but this muscle wasting is cardiac cachexia. So there is an inflammatory process associated with this, but this is likely to be more a consequence of the congestive heart failure, particularly right-sided congestive heart failure, rather than the actual mitral valve disease on its own. So we're going to go back, and then we're going to have a little more of a think about the role of the valve interstitial cell and the sort of pathogenesis of mitral valve disease. So these are this is another EM image from one of the publications of Brendan Cochrane, and it shows that we have this sort of interplay, or this apparently communication between endothelial cells and the valve interstitial cells. So they seem to have this reciprocal interaction to favour sort of normal homeostasis, and we have activation of our valve interstitial cells with mitral valve disease, and they changed to more of a instead of a fibroblast-like, they changed to more of a myofibroblast-like phenotype. So they will now express smooth muscle contractile proteins. In cell culture, activated FIX do become contractile, and it may be that that is a compensation for an abnormal valve. They're trying to maintain valve tone and maintain valve function. They're also expressing matrix metalloproteinases and inflammatory cytokines, and this results in this rapid remodeling of the extracellular matrix that we talked about. So they'll end up with a disorganized matrix, accumulated glycosaminoglycans and proteoglycans, the disorganized collagen fibrils, and then we have this increased retention of water as well. So there's been a lot of work recently looking at signalling pathways in mitral valve disease, both in people and in dogs, and there are some similarities and some differences between humans and dogs with mitral valve disease. So again, this is from Brendan Cochrane's group, Greg Markby and colleagues, but they've shown with transcriptome analysis that TGF-beta1 is the dominant aberrant signalling pathway in both canine and mitral valve disease conditions. So the TGF-beta1 pathway probably both initiates and sort of perpetuates this progression of degeneration in the valves. So there's good evidence for the role of TGF-beta. So it's increased in diseased valves, looking at its expression. If you have cell cultures of your valve interstitial cells and you give them TGF-beta1, then they will actually become activated, having been previously quiescent. And we also know that the valve interstitial cells produce our TGF-alpha. So there is interaction between the TGF-alpha pathway and the serotonin pathway. So on this, diagram here, we've got our TGF-beta receptor, and that can do a couple of things. It can activate the canonical SMAD2/3 pathway, and it usually does this in people rather than dogs, and then we'll end up with the activation of the valve interstitial cells, and that can cause more fibrosis. In dogs, it's more likely that it does this extracellular regulating kinase pathway, which comes down through RAS, and then we have this cell proliferation and more extracellular matrix production, but less fibrosis. So this is the non-canonical pathway. We can see this interplay between our serotonin with our 5-HT receptor as well, and this will go through sort of G protein, phospholipase C, protein kinase C, and also contribute via the ERK pathway to our extracellular matrix production. 5-HT doesn't activate valve interstitial cells on its own, but the TGF-beta1 will actually activate the serotonin pathway, but there is interplay between both of those things. So to think a little bit more, there's been a very nice review by Mark Oyama about comparing the 5-HT and TGF-beta mechanisms recently, but we have evidence for serotonin. If you have high serotonin levels, we have the serotonin syndrome, and that can cause valve disease, typically right-sided heart disease, or right-sided valve disease in people. So this could be associated with drugs like our diet drugs or weight loss drugs, the fen-phen pathways. We can have tumours of the endochromatin system that produce serotonin, so kind of carcinoid syndromes. We can have experimental models where they have higher serotonin levels, and all of these cause valve changes, myxomatous degeneration of the heart valves. So serotonin itself, if we've got free serotonin, that serotonin is produced from tryptophan by tryptophan hydroxylase. So once we have serum serotonin, it can have various effects. So it can act it can be taken up by platelets first of all, but it could also be act on your serotonin receptor, which is your 5-HT, and in the heart valves, it's your receptor 2B. And this is sort of looking at the pathways we looked at before with the ERK pathways and causing more extracellular matrix production. There's also a serotonin reuptake receptor, SERT, and this will also take this up, and it will break down your serotonin into 5-hydroxyl indole acetic acid. So that's catalyzes by monoamino oxidase, and 5-HIAA is excreted in the urine, so it's inactive, and people have looked, the Copenhagen group have looked at whether different levels correlate with different parts of the heart disease. So what we see with mitral valve disease is that our serotonin receptor, our 5-HT2B, is upregulated. Our tryptophan hydroxylase is upregulated. All of both those things are kind of increasing the amount of serotonin available and the effects of the serotonin. But our SERT receptor tends to be downregulated. Okay, so again, there's less uptake by SERT. There's probably more serotonin going around to be available for progression of this disease. So we know that dogs with dogs with mitral valve disease have higher serotonin levels than our healthy controls. And cavaliers have higher serotonin levels than anybody else. So this might be why cavaliers are always fairly happy, regardless of what's going wrong with them. And SERT expression is downregulated in dogs with mitral valve disease. So the serotonin levels actually tend to be higher in your sort of earlier stages of mitral valve disease, and then they tend to decrease again with the late stage disease. So what all causes this? Why do dogs actually get mitral valve disease? So I guess it's part of being a dog, because we see it so commonly in virtually all dogs once they get old enough. And the actual etiology is still not known. It's still very poorly understood. So this group from Korea have actually identified, they looked at SERT, the serotonin transporter protein, and they showed that when they looked at Maltese dogs, and they compared 20 Maltese dogs with mitral valve disease and 10 controls that were over 10 years old, but they didn't have mitral valve disease. This is a sort of candidate gene approach, and they sequenced the SERT, and the controls were the same as the sort of canine Canis familiaris reference sequence. But in mitral valve disease, there were a number of different polymorphisms on single nucleotide polymorphisms in 5 exons, and 3 were predicted to be probably damaging. So it could be that there's this association between the SERT gene and mitral valve disease, but it doesn't look like a causal mutation, because this wasn't just one mutation. The authors actually went on and did a genome-wide association study, and they actually identified a locus on chromosome 17, but this is different from where the SERT gene is encoded from, which is likely to be chromosome 9. So the Copenhagen group actually have looked at the SERT gene in cavaliers and haven't found the similar polymorphisms in cavaliers. But they have this in the LUPA project, which is an EU-funded project with a multi-centre study. They looked at cavaliers that had premature onset of mitral valve disease and compared those with controls that were over 8 years old and had no or minimal mitral regurgitation, so late onset disease, if you like. And so the inheritance is believed to be, of the age of onset is believed to be inherited. But this was looking at unrelated dogs and comparing these two groups. So they had 139 cases with 102 controls, did genome-wide association study, and identified significant loci on chromosomes 13 and 14, but there's still no known gene defects associated with that. So Anne French and colleagues from Edinburgh actually did a similar thing looking at cavaliers. They had a sort of slightly higher age of the cases and a slightly lower age of the controls, but they only had 18 in each group, but they didn't find any significant loci. They were thinking this would probably be more like to be a homozygous condition, or dogs with the premature onset would show homozygosity, but they didn't find anything, and they certainly didn't find anything at the chromosomes 13 and 14. So it's still a case of watch this space. We still don't know what actually causes it. As I said, the premature onset of mitral valve disease does seem to be inherited, and so this has been well published by the Swedish Uppsala group with Svensson and colleagues. So they looked at the relationship between parental status and then the progeny and what age did they get mitral valve disease. So they showed that this was strongly inherited, and this led to a sort of commonly used heart testing scheme, including the old British heart testing scheme, which basically said you can breed your dog once it's 2.5 years old as long as it's free from any heart murmur, but it must have parents that are over 5 years old with no heart murmur. So you're trying to breed them at the normal age of breeding, but not prematurely, and you're trying to look at parental status as well. And very sadly, and I know Simon Swift's very sad about this, this did not lead to any difference in the prevalence or the age of onset of mitral valve disease in our Cavaliers in the UK. In contrast, the Danish scheme was very, very successful. So this is Lisbeth Olsen's group. I've mentioned them a couple of times before. They do some amazing work. But they actually had these sort of similar restrictions. They advised against breeding from young dogs that had onset of mitral valve disease. So they had, over 1,000 of dogs that had between 1 and 4 evaluations. The Danish regulations are that they're screened at 18 months, at about 4 years old, and then the males are still screened again at over 6 years old. So they compared the sort of results they had between 2002 to 2003, and then the 2010 to 11. And the Cavaliers in 2010 to 11 that were products of this breeding scheme had reduced odds of mitral valve disease at a young age. So there was a 73% reduced risk of mitral valve disease. So the Danish scheme does work. So what does the Danish scheme do? So this relies on echo, not just the audible presence of a heart murmur, which will depend on the noisy environment that you're hearing on the day, the quality of your stethoscope, and the stillness of the dog. So what we mean by mitral valve prolapse, we can see here. So when this is a stage B1 mitral valve disease dog, he did have an audible murmur, but you can see that parts of his mitral valve are prolapsing up beyond the hinge points of the mitral annulus. So in the still images, what we're looking for is if we draw a line from the hinge points of the mitral annulus across the mitral valve during ventricular systole, then any part of the valve that's prolapsing up is the degree of your prolapse. So in the Danish scheme, they look at the prolapse of the anterior leaflet, the posterior leaflet, and the coaption point. Whereas in the British scheme, we just look, and this has only just started a year ago or so, we just look at the maximal prolapse because that proved to be much more repeatable. And obviously we can't necessarily get all of these prolapsing optimized in one single image. So this is the sort of UK scheme at the moment based on the Danish scheme. We have our severity of prolapse from grade 0 to grade 3, depending on how much we measure for that prolapse. And then we also do rely on the presence of the heart murmur. And so the scoring system is the presence of the murmur and the degree of the prolapse. So in a 2-year-old dog, if you have no prolapse, no murmur, you're green and you can go and be used at breeding. But then if you're only 2 years old and you have a murmur, then you shouldn't be bred from. If you have quite a lot of prolapse but no murmur, you still shouldn't be bred from, or at least there's a warning against being bred. And obviously more severe disease on the traffic light system is stop, do not breed. So you have a bit more leeway. If you're older with minimal changes, then there's more encouragement to be used at breeding because you're likely not to have premature onset of mitral valve disease. So we'll need to see how this works as far as the UK scheme is concerned. Okay, so just to look at some sequelae of mitral valve disease. So this is as the disease progresses, you've gone beyond the congestive heart failure. These are the kind of things that can happen to dogs. So most of our patients with end-stage congestive heart failure need to be euthanized. It's quite rare that they have just die at home or have a sudden death. Quite often it's because they have significant comorbidities such as chronic kidney disease or azotemia on a high dose of diuretics. One of the things that can lead to sudden decompensation is the onset of atrial fibrillation, and as we've already said, this is a bad prognostic indicator, and we can see it even in small breed dogs because of the degree of atrial stretch. So by losing that atrial contribution to ventricular filling, we reduce our cardiac output and they will decompensate. Another common complication is the development of pulmonary hypertension. So most dogs with valvular heart disease will have a degree of tricuspid regurgitation, and we can measure our tricuspid regurgitation velocity to estimate the severity of any pulmonary hypertension. So in this example here, we're using our modified Bernoulli equation. We've ruled out any right ventricular outflow tract obstruction or pulmonic stenosis. So we're using our pressure gradient between the right ventricle and the right atrium as approximately equal to the systolic pressure in the pulmonary artery. So if we measure our tricuspid regurgitation velocity here, such as in this example, it's about 4 meters a second. We apply our modified Bernoulli equation, so 4v squared is approximately our pressure gradient, so that's 64. And we've ruled out pulmonic stenosis, so we assume that our pulmonary arterial systolic pressure is about 64 millimeters of mercury. So why do dogs with mitral valve disease get, with left-sided heart failure, get pulmonary hypertension? So this is because of the high left atrial pressure gets transmitted across the pulmonary vascular beds to cause pulmonary capillary and then pulmonary arterial hypertension. So this is called post-capillary hypertension. Now, many of these dogs may have concurrent respiratory disease as well, so they might have bronchomalacia, chronic bronchitis as a cause of some of their clinical signs, or there may be a component of both of these. So one of the things we can do to try and discriminate between those in a dog with pulmonary hypertension is looking at the pulmonary arterial to left atrial gradient. And one of my colleagues, Sid Sedona-Gunter, has looked at different echo ratios to try and differentiate between pre and post capillary pulmonary hypertension in dogs. But actually he found that the ratios that we can use, the estimated pulmonary arterial to left atrial ratios, were no better in dogs compared to humans, compared to just estimation of left-sided filling pressures. But this can cause signs of sort of exercise intolerant or exercise intolerance, or even syncope, or even shortness of breath, even without having any pulmonary edema. So another sort of devastating consequence can be, or even just a minor consequence of mitral valve disease, can be these chordae tendineae. So if we remember that the chords are also affected by this myxomatous degeneration. And so we can have something like this. So this little dog had atrial fibrillation as well. And if I slow this, it's really difficult to see, but if we slow it down, you can see there's this little strand of cord just flicking up onto the left atrium during ventricular systole. So on the still image, that makes it easier to appreciate. And then obviously associate with very severe mitral regurgitation as well. So we can rupture the chordae, mostly if this is, especially if this is a primary cord, the dog decompensates, develops a severe pulmonary edema, needs to be restabilized. But actually it's not that uncommon to see evidence of ruptured cords, both on echo and during a post-mortem examination, and you just sort of accelerate or step up the diuretic treatment. So another thing that can happen is that we can end up with endocardial jet lesions. So this mitral regurgitation is damaging the endocardium within our the left atrium, and we can have jet lesions that we can see, but we can also have perforations. So then we'll have a left atrial tear, and we'll typically see this, that there's suddenly a change in the dog. So the murmur grade becomes less, or muffled heart sounds. They may be collapsed because this pericardial bleed, pericardial hemorrhage, causes cardiac tamponade. And so these are sort of compromising the cardiac output. And the way we'd recognise this and discriminate it from any other cause of pericardial effusion is that there's a massive big left atrium here. And if we look around, we can sometimes see evidence of a clot sort of hanging off the left atrium here on this sort of left apical two-chamber view. So that can be a consequence as well. They're quite difficult to manage because we're trying to think about, you know, not draining the pericardial effusion, or there's going to be more bleeding, but the congestive heart failure is compromised as well. So we can have different types of left atrial tear. So this was a Cavalier case that didn't have a prior echo. So I don't know if this atrial septal defect pre-existed, but certainly it has been described by Gordon Peddle that atrial septal defects can be acquired secondary to these jet lesions. In a way, this is good because this is allowing the left atrial pressure to be sort of turned off a little bit by going into the right atrium. So it may be protecting the dog against left-sided congestive heart failure. So just as a peculiarity. So the kind of conclusions then, we all feel we know all about mitral valve disease, and it's very common. It's our bread and butter for general practitioners and for cardiologists in referral practice. But actually there's been a huge amount of work recently looking at the sort of different mechanisms, the pathological changes, the signalling pathways and the pathogenesis that are being actively researched. And I hope I've summarised some of those things for you today. And I hope this gives us, if we understand these signalling pathways and things especially, maybe that gives us more avenues to explore as far as treatment interventions and things as well. So we can maybe modify these pathways to reduce disease progression in the future. And I certainly learned a lot preparing this, and thank you very much for listening to it.